Good morning, everyone, and welcome to the Public Safety Solutions for Substance Use Disorder ECHO. My name is Julio Soroblanco, and I will be the facilitator for today's session. This ECHO is brought to you by the Center for Substance Use Training and Telementoring, also known as CSTAP, by Beeville, Texas, in collaboration with the UT Health San Antonio ECHO program. A few housekeeping items before we begin. We have live closed captioning available for today's session. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. If you're having trouble accessing captions or having connection issues, please chat Echo IT Cato for any assistance. To help us with attendance, please enter your full name, affiliation, and email into the chat. Please remember to stay muted unless you are speaking. We encourage joining by video and using the chat and/or raise your hand feature to pose questions or share perspectives throughout the session. As a reminder, these sessions are being recorded and will be shared on our website. To ensure privacy, no personal health information is allowed at any point during the session. This includes any client or patient names, addresses, birth dates, or any other identifiable information. At the end of the session, the ECHO team will send out a post-session survey link. We kindly ask you to complete it as it provides feedback on how to refine these sessions to better address your priorities. We are approved for CEs for paramedics and any public safety professionals with a behavioral health degree, such as social work or counseling credential. Finally, ECHO is an all-teach, all-learn environment, and we do encourage everyone to participate in the conversation and raise questions. With that, we'll go ahead and move on to some team introductions. First up, we have Jeremiah Golka.
Hi, everybody. Thanks for joining today. I understand it may be a spring break in some places here, so if folks are here, that's appreciated. I'm the senior advisor at the Shield Training Initiative. We provide occupational health and safety trainings for law enforcement, criminal justice folks regarding their work in response to the overdose crisis, making their work and lives better, and at the same time helping lead to better encounters and outcomes for people who use drugs.
Thanks so much. We also have with us Dr. David Miramontes.
Hi, good morning. I'm Dr. Dave Miramontes. I'm the medical director for the San Antonio Fire Department. I'm sorry I'm late. I was actually prescribing by telemedicine one of our clients that we interacted with today that suffered an overdose. So our fire department does a lot of overdose work, and we are a prescriber, and we get people referred into wonderful treatment centers across the San Antonio area. And I'm glad to be here.
Thank you so much, and we're happy to have you, Dr. Miramontes. We also have with us our case presenter today, Joe Ortiz.
Hello, everybody. Thanks for the invite to come out today. My name is Joe Ortiz. I work with the City of El Paso Fire Department Community Health Division, which oversees our MIH services, our mobile stroke unit, our flight program, and everything EMS. So thanks a bunch for allowing us to be here today.
Thanks so much for being here. And lastly, we have Cynthia Mendiola. She is our last sub member and our case presenter for today.
Good morning, everyone. Happy to be here today. My name is Cynthia Mendiola. I'm a retired federal probation officer, also work in immigrant safety, and a trainer and coach in core correctional interventions. With that, do you want me to begin the session?
Yeah, go ahead.
Okay, well, today's session, thank you for being here again, is on building bridges, reentry, best practices for persons with substance use and mental health challenges or disorders. Some of the disclosures that we have in this program is all speakers and all members of the planning committee have no relevant financial relationships with a commercial interest to disclose. And then the views expressed do not necessarily reflect the official policies of UT Health San Antonio, the Department of Health and Human Services, or Texas Health and Human Services, nor does mention of trade names, commercial practices, or organizations imply an endorsement by the US or the Texas government. So today we're going to be looking at some of our learning objectives, and that's to discuss critical areas within the reentry process where interventions can support individuals with substance use and mental health disorders. We're going to also analyze some statistical facts about individuals coming out of the confined facilities, prisons, and jails, and then identify barriers that justice-involved persons encounter during their reentry to the community. We will ultimately look and evaluate reentry best practices and activities that contribute to a successful continuum of care for individuals with substance use and mental health challenges and co-occurring disorders. So reentry, why does it matter? Why is it important? We focus on the period of the time prior to a person's release. So reentry is really important because we're looking at some numbers here. Out of 448,000 or 449,000 individuals released from prison, 315,000 were on conditional release. And when we talk about conditional release, we're talking about individuals that come out into a supervision period with conditions. Either they're, conditions to not use drugs, not drink, be stably employed, make sure you have a residence, and just some of those conditions that are imposed. And then we look at the average annual cost of a person being incarcerated. And I have, for the Bureau of Prisons, which I'm mostly familiar, it's the federal prisons, it's over 28 or 29,000 per inmate. And then you look at the disparity among many states coming between, from the research that I've done, between 23,000 and into the 100,000s I've seen. I still don't understand why it goes into the 100,000s, but those are the numbers. You also look at residential reentry centers. These are centers, they're like halfway houses, they're transitional centers. They're for individuals that are coming out of prison that go into these centers to start working on how to transition into the communities, okay? And so the cost for that is approximately $27,000 for those individuals to house them, to work through services and resources. And then you're looking at community supervision, which is the probation, parole, county probation, supervision periods. And the cost for that is approximately $2,800 to $3,300 for that supervision period. I think it's important to say that for individuals that are coming out of prison or jails, the residential reentry centers, the halfway houses, the transitional centers, it's really a necessary period of transition. And that is to ensure that the needs are met before actually moving into the community. And so the cost at that point is necessary, in my opinion. Reentry is not keeping track of individuals releasing from prison. It's being proactive and helping individuals to transition into the community with meaningful services. So not all of the services are going to fit everyone's needs. So assessments are necessary to ensure that the services match the person's current condition in many specific areas, which I'll go into in the next slides. But the last point that I wanted to make on these numbers is that 45% of prison admissions are the result of probation and parole violations. This is an annual cost of $2.8 billion for just technical violations. And when I talk about technical violations, I'm talking about someone giving a urine specimen that is positive for a substance, a drug, and either an illicit drug or an illegal drug. An individual that can't keep employment, an individual that commits a shoplifting crime. And one thing to understand is that an individual that may commit a shoplifting crime may be an individual that has untreated mental health symptoms. And so it's just really important to understand that some of these technical violations can be avoided or can be somehow mitigated through appropriate services. And then lastly, 9 million people cycled through the jails. I think these are overwhelming numbers and important to understand and see. So what is the goal? What is the goal of reentry? And we look at not only for community supervision officers, but also for all of the people that touch the person's lives after incarceration. So the goal, a seamless transition into the community, a focus on individuals releasing from custody with substance use and mental health problems. To also, part of that goal, provide a robust continuum of care and treatment services, and then ultimately strengthen protective factors. Protective factors are stable employment, family support, and then the recovery. So early reentry planning is key. It's targeting risk factors and reduce recidivism. It's looking at those risk factors for antisocial peers, antisocial attitudes, values, and beliefs, and then identifying and using core correctional interventions to address those risk factors. So starting ahead to remove some of the barriers encourages and provides hope in success for these individuals. But we have to look at some primary and overwhelming barriers. At release, formerly incarcerated parents owe an average of $20,000 to $36,000 in child support. And this is a number that they have an overwhelming debt that they come out with at the time of their release from any of the institutions, even jails. The other overwhelming factor is that an unemployed releasee is 3 to 5 times likely to return to prison. And then within the first 90 days of release, and this is at the time that they come in contact with beginning their supervision periods or supervision term, the risk of overdose, suicide, and rearrest is really high. Ultimately, at the end, we also look at an overwhelming situation for a lot of these individuals, and that's many of these releasees come out with suspended driver's license or lack of transportation, which is a major barrier for them. But let's look at some barriers for just individuals with substance use and mental health problems. We look at individuals that are in prison that are prescribed medication while incarcerated, and we look at the fact that they only come out with at 1 week of supply, resulting in untreated substance use and mental health problems. And so we look at these individuals that are coming out of prison, getting their medication while in prison, and only have a week's worth of some of that medication that they need in order to continue in their recovery. Some research that I've done, some research results indicate that individuals didn't receive or failed to report prior treatment for mental health or substance use issues. So you have these barriers that are coming forth where there isn't any information at the time of supervision that an individual is needing services. There are also emotional barriers of survival in prison. And these are barriers because individuals that seek behavioral health care in a confined facility it shows that it's a sign of weakness or vulnerability. And then that is key in a prison setting or a jail culture. It's a barrier for their survival in prison. And again, within the first 90 days of release, for example, you have overdose and suicide is very high. I've talked about that in the previous slide. And then we also have to remember not to exclude rearrest for minor crimes rooted in basic human needs. Ineffective lines of communication results in gaps in services. And when we talk about ineffective lines of communication, I'm talking about between community supervision officers, treatment professionals, case managers, and prison staff. And then again, ultimately, another barrier for individuals that, in working with individuals with substance abuse and mental health problems, it's a lack of knowledge or specialized training. And for community supervision officers, the lack of specialized caseload leads to processes rooted in evidence-based practices getting lost or incorrectly applied. You also have many professionals, treatment professionals that have not worked or don't have the experience to work with individuals that have been incarcerated, and that also becomes a barrier at times. So what are the areas of target in reentry? Some of the areas that we need to work on in reentry is primarily the substance use and mental health services. So it's the individuals that have these disorders that we have to target primarily before they come out of the institution. Sorry. Setting up continued treatment services prior to release for relapse prevention, harm reduction. And when I say harm reduction, I'm really talking about resources that are important for them prior to coming out into the community. Resources like Narcan. What is Narcan? Where can they get it? How can they get it? And when to use it? It's also important that individuals that went into prison before using know what's available and where they can get the needle exchange programs to help them in situations that they tend to relapse. Transitional, also mental health services, transitioning into continued medicated assisted therapy services. Make sure that they have prescriptions beyond the 1 week, that they're transitioned with those prescriptions to move on into a period of supervision without any interruptions or gaps of services. Other targeted areas for reentry, but I do want to make this point, is that before we can even work in workforce or vocational training or any of the other targeted areas, the substance use and the mental health symptoms for individuals with the histories in these areas has to be addressed first. And they have to be in a stable situation in order for anything else to be effective. And so workforce and vocational training, the use of job readiness folders, mock job fair interviews, information, updated vocational programs, apprenticeships, and resume information prepared in the prison are important resources to transition into the community with this individual. We look at other areas for reentry is housing, to assess a stable family support prior to the person coming out, locating felony-friendly housing complexes, and then we move on to the medical, where we have follow-up referral to rule out or rule in any medical issues before the individual comes out into the community, have those services ready if needed. And then we look into transportation, providing assistance with tokens or transit passes. So these individuals can get off the ground running into all of these other services that I talked about, these other areas. And then ultimately, documents, which are really important for someone to transition into the community, to the workforce, even getting services in the areas of mental health and substance use. So what are some of the best practices for these individuals? How am I on time? Am I okay on time? Almost done. Best practices for some of these individuals is reentry practices is the first thing is we start with collaboration. It's really important that at every juncture or every agency collaborates, the officers with the behavioral health professionals, with case managers, and I put inmate skills development coordinators, which is the title that is given to individuals in the federal prison, but I know there's a synonymous title for the state prisons as well and jails.
You have like 8 minutes more, Cynthia, just so you know. So no problem.
Thank you so
We're
much.
good. You're good in time. Thank you.
So these are the key players and the champions of these individuals who can make a difference by the start of the 90 days upon release. So we're looking at the first 90 days, people are really at high risk to go back to prison because of many different things, different pathways for individuals. And that's just another training in and of itself, looking at the pathways that people end up in prison, or jails. But let's look at some of these key players and at what periods of reentry. So we look at reentry supervision period, which is removing the barriers, and that starts in the prison system. We transition into continued medicated assisted therapy services. We staff and review assessments with treatment professionals to determine what treatment program matches the needs of the releasee. Co-occurring treatment services to match the needs. And also, this is really key. A lot of times, many forget that we have to ensure there are gender responsive programs available for female offenders, because many of these individuals do not do well in mixed groups. And a lot of times we forget that. So we look at the next stage of reentry, and that's the community supervision period. We, as probation officers, are looking to incorporate treatment assessments to include medicated assisted therapy and treatment programming, implementing next level of treatment into the case planning. And this is really important. I'm just not saying words, but when I say implement next level of treatment, it's not reinventing the wheel. It's not starting somebody in treatment all over again, which is often happens, and it's the shortcut and a cookie cutter approach to services that are ineffective. It's looking at what did the person go through in prison? What was the level of treatment? Where are they in their stage of recovery? And moving forward to linking them to that particular stage of treatment, and so that they can transition and move forward. Because remember, we have to remember that over-treating an individual can also put them at a high risk of relapsing. Excuse me. Include, in the community supervision period, we have to include the major two risk factors into the treatment programming. The major two risk factors is antisocial attitudes, values, and beliefs, and association with antisocial peers. Those are the two major risk factors that usually result in recidivism, and those have to be targeted in the supervision process and the treatment process for these individuals that come out of prison. Community supervision also involves helping to set goals for supervision period and beyond. And when I say beyond, I'm talking about what are the goals this person needs to have while on supervision, and do those goals follow through, be past supervision, so that they continue to be successful and continue in a positive way in their recovery. CB and PS skill building, that means cognitive, behavioral, and problem-solving skill building is essential interventions for targeting some of the high-risk factors that I mentioned a few minutes ago. And then we also look at relapse prevention, which is necessary for substance use and mental health individuals, and also risk behavior to address while on supervision and in the treatment programming. And then lastly, job retention planning, referrals to workforce and the workforce professionals. And that's a typo, I'm sorry, I put classes on there. It also means role-playing work scenarios, being active with the individuals to ensure that they are having real life practicing, interviewing, and also assisting with resume writing and reviewing their resumes to make sure that they're updated. And then ultimately, job readiness classes for individuals that have chronic unemployment periods and haven't been able to be able to maintain employment for a long period of time. Those are important for individuals to transition into a good workforce. So in reviewing some of these things, and this is just, I mean, it's just really just a, what can I say? It's a snapshot of what's really important. And there's so many things that that are involved in it. But in our everyday work, we see how it is difficult for people to change, more so when individuals are challenged with mental health and substance use disorders and periods of confinement. Bill Miller, the founder of Motivational Interviewing, talks about what people need in order to continue forward in changing their lives in a positive way. He talks about change is a gradual process that requires patience and persistence, and how support systems play a crucial role in facilitating movement through the stages of change. And with that, I give you back to our lead, Julio.
Thank you so much for that great presentation, Cynthia. Um, at this time, I'd like to open up the space to the learning community. Are there any questions or comments from y'all for Cynthia on her presentation?
Hey, it's Dr. Miramontes. Great job. And I have to tell you that I am just tickled pink that our state and federal partners are actually doing active buprenorphine treatment in the institution. And this issue of the transition is a big deal. I probably get one or two a week, actually, of folks coming out of the jail, coming out of the state or federal prison. And the story's always the same. Oh, they only gave me a week worth of prescription and I don't know what to do. And I don't know about where everyone else is. It could take 1, 2, 3 weeks to get an appointment with a prescriber for a new patient. So this is a big gap that unfortunately our probation officers and reentry staff they have to navigate. So that's a big deal. And Cynthia brought out another really great thing that is worthy of note, and that documents. So a lot of these folks don't have an ID. The only picture they have is their jail ID or their prison ID. That's it. They don't have a driver's license. They don't have a state issue ID, which makes it really challenging for them to do banking, to do the job search, to pick up a prescription. You can't pick up buprenorphine if you don't have a picture ID. So these are all real important challenges for these folks. And then anybody trying to get someone to see a psychiatrist in a week, yeah, that's not going to happen, right? So they need refills on their psychiatric medications. So this is just a challenging group of individuals that are just ripe for relapse or to fall through the cracks if they're not aggressively managed. So good job, Cynthia.
Thank you, Doctor.
Lindsay, I see you have your hand raised. Feel free to unmute.
Yeah, so good job. And I really agree with all these services. But at the same time, I question why we're putting people in jail in the first place with these disorders, especially people that have done nothing wrong other than, like, I don't know, carrying drugs that they're using, right? That are illegal. So, like, while these services are great, they're also really expensive and time consuming and unnecessary if we just get people the help they need instead of throwing them in jail in the first place.
Yeah, totally agree. Yes, we're preaching to the choir, aren't we? And so I think that's important to note that, I mean, if we go to Congress, if we go to the legislature and say, look, the cost of this is just enormous. Let's concentrate in these other areas more and let's get those resources. Yeah, definitely, I agree.
Diane, feel free to unmute.
Hi, this is Diane Thomas with Bell County Juvenile Services. We also have the same issue as Mr. David had said. When the juveniles are released from custody, they are medicated while they're in placement here. But once they release, following up with the meds is really been a struggle and a challenge, not only for the parents who probably don't have transportation, and sometimes they don't even have residents to release to. And so that's also been one of our biggest challenges with our juveniles here in placement.
Yes, thank you, Diane, for saying that, because we often forget our young ones, and those are the most important population that we really also have to target and work on.
Jody, I see you have your hand raised. Feel free. Oh, it looks like you're muted.
I think that would be very helpful is that all these programs are really good and they have all different uh, entities that are helpful in getting them back into the society and stuff like that. But I think when they come out, if they could get hooked up with just one person and not a PO that has a certain role and not the different people that have their different roles, but one person that is like a mentor that would help them navigate to those different entities that would help them in their and what are their doctors or their recovery coaches or whatever they needed, because they all have their roles. All those people have their roles and they stay in their lane, right? But if they have one person that hooks up with them and just kind of helps them navigate that stuff, because when they come out, they got their minds going all different directions, but if they have somebody to help them and stay grounded to and stay accountable to, I think that would be really helpful. And that could be a position that they could, it would have to be a position they'd be trained for, because they'd have to learn how to do all those kind of navigating. But I think that'd be very helpful that they were just connected with one person, and that one person would have like several people connected to them. It wouldn't be just one-on-one only, but that one role would have like 20 people that would be connected to them. But I think that would be very helpful for that individual coming out. They would know they could always come to that one person when they needed the different things to get back into their get back into life.
Yes. Yeah, I think that there's something similar to what you're saying. They're key players also, and that's the peer support individuals that follow the person and walk with them through whatever these people have already experienced. And those are important as well. They're key players. I didn't mention them in there. I put them under the professional, treatment professionals, because they are tied into the treatment agencies. Good point.
Lindsay, go ahead.
Yeah, so we do have programs that go into the jails and prisons to train peers, but they're very scattered throughout Texas. Unfortunately, there's a lot of barriers to that, right? Like, we want reentry peers, so people who have been through that to go back into the jail and train, but there's a lot of barriers to that. So if y'all can advocate for peers being allowed to go into prisons, that would be great. We would definitely love more of that across the state. But they're all individual too, right? We can't just say they can go into prison. We have to go to this prison or that, and that makes it difficult.
Thank you so much for sharing that. Francisco, I see you have your hand raised. Feel free.
Yeah, so I was just going to share something. I was actually incarcerated. I was formerly incarcerated. I was actually a peer coach in prison, and this was a natural progression for me to become a peer support specialist. And it is hard. The barrier from when you get out. I've only been out 6 months, and one of the biggest challenges when I was teaching in prison was telling these guys about awareness, trying to get resources for them, places to go to in whatever city they were going to end up paroling out to, or whatever halfway house they were going to. And so a lot of it that I see is awareness. Some people just don't know where to go to where they can get additional resources that's going to help them, and it's hard. It's because a lot of some organizations change, and so it's hard to keep that in a database or on a spreadsheet and provide that to them while they're in there. But if it changes, and so it's a challenge. But
Francisco, when you came out of prison, did you get an opportunity to go through a residential reentry center or a transitional center?
I had to do 2 months at the Cheyenne Center in Houston, and that was um, 60 days. Some people, when you're coming out of prison, you either do 60 to 90 days, and one of those 90 days if you've had multiple, if you've already had was at a halfway house previously in a previous incarceration, you have to do 90 days there. For your first time, you do 60 days, and then you get a successful discharge, and then you get to go out to friends and family, or find sober living house, or you find a new place to live.
Right. But
it's
you were in a different county and then you ended up in San Antonio. So that's kind of difficult to transition from
it
another
is
county into your home city, right?
absolutely, absolutely. It wasn't
There's a
from.
gap there, right?
There was a gap there from Harris County to going into Bear County. Now, I will say, in all fairness, Harris County, they were really good. They have Harris Health. They were really good about when I was at the treatment center. You sign up for what they call the Gold Card. Everybody gets that, and I mean, you can go get medication. You can go to doctor's appointments. You can go. They do have mental health services. That's really great. That's one of the better things about Harris County and Harris Health, and it's free while you're at the halfway house. Now, if you continue to be if you live in Harris County, you can continue on that. But obviously, if you move to a different county like I did, I had to get on CareLink, and so it was a bit of a challenge. But it's possible, but you have
And then
to
in
really have to work at
Francisco,
it.
that's
Mhm.
coming out of a state prison, correct?
No, yeah, it's coming out of the Texas TDC. Yes, that's correct.
So I think I just want to make note that like in the federal prison, they tend to do reentry and bring people into their communities, like in the counties they live or whatever. So they try to do that where if they're in a Kansas institution, they bring them all the way to San Antonio, if this is where they live, and they put them in a residential reentry center from 4 to 6 months so that they can start acclimating and getting used to getting all their medical stuff. It doesn't mean that there still aren't any gaps, but I mean, it's an attempt.
Great. Thank you so much for all of that great conversation. In the interest of time, I'd like to go ahead and move forward to our announcements for today. Kato, thank you so much. To claim your CEU credit, you must complete the post-session survey in the chat or by the email sent after the session. Complete the post-session survey and select yes on the question, are you applying for CEU credit for today's ECHO session? Your certificate of completion will be sent to you 2 to 3 weeks after the session date. If you have any questions, email bewelltexas@utesca.edu. Next slide, please. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics via our team of experts. To request technical assistance, please complete an online request form and we'll be pleased to help you. Next slide, please. Do you have a difficult case that you or your team have encountered? CSTAT offers you the opportunity to present any challenge your organization is encountering and receive feedback from our hub of experts and broader learning community. There's no need to prepare a formal presentation. We will provide a case form to fill out to assist with your case presentation. Please email us at cstat@utesca.edu. Next slide, please. And please join us for our next Public Safety Solutions for Substance Use Disorder ECHO on Thursday, April the 9th at 11 a.m. Central Time. All right. With that, let's go ahead and move on to our case presentation for today. Kato, if you can please bring up the case form. Joe, please walk us through your case.
Hello, everybody. I'm going to go ahead and set my timer because I know I got 5 minutes. And I like to talk about this stuff. So I'm going to try to save you guys from a long-winded presentation. Just real quick, I mean, all the stuff that you all were talking about right now I think is challenges that everybody's facing. With us, especially with the mental health substance abuse, we find that a lot of times that there's a huge gap in that safety net right after they overdose, after they get out of substance abuse programs and stuff, and they tend to relapse a lot. So we try to do our stuff like on an inverted triangle per se. We've started off small and we're trying to get bigger. We've learned a lot from Dr. Miramontes' team through San Antonio, and they kind of gave us a launching board. So what we ended up doing here on a typical day, we usually do Narcan distribution based on our stuff with overdoses, and we were starting to go out into the community, interact with these individuals, and provide those services and education. But what we did find is that we went out, but these individuals needed a lot more than just us, talking to them. So what ended up happening last year is we had a multi-agency team that came together, because what we found is we started getting into each other's lanes. We were shifting and we're like, oh, you're doing this, I'm doing that. And we found that we could really complement each other's services. So instead of us just going out and doing Narcan distribution, trying to find housing, that required a lot of resources and going back and forth. So through Veterans Affairs, they asked to do a drive for veterans, the homeless veteran population. But the city said, yeah, let's do it, but let's actually do it for everybody. So the initial plan was just to work with those veterans, but we found that a lot of individuals within the community. So we found out that, you know, our innovations team handled housing stuff, animal services. We understand these individuals have pets. We had the mobile integrated health team that was the navigation and stuff. So we brought all those together and we divided the city into 3 regions. What was good about this is that city council was very for it, because sometimes the individuals get hurt when you're not doing programs out in their particular constituents. So we actually brought everybody together over a 3-day period, and we actually went out to some of these encampments with the homeless population, dealing with them. We know that homeless individuals also have the substance abuse challenges and things like that. So we brought our specialty to that. And what we ended up doing was we would go out, we had volunteers. If they needed housing or anything, everybody was there. And it wasn't a large cost put to it, right? Because I know that sometimes some of our programs are limited because we're grant funded or what have you. But this allowed us to like really get out in the community as a whole and get everybody together. And then so when we approach these individuals in these encampments, we had the resources at our hands, at our fingers. Like, how can we help with this? How can we help with that? And it allowed us to have a pretty successful drive doing that. I got an updated thing. We ended up seeing over 300 individuals. We handed out about 85 things of Narcan. You know, we were servicing pets also. We were getting individuals to go into the homeless shelters, get them registered, because a lot of times I think the navigation portion of it is difficult for these individuals. Like we're talking about with the prisons, where do I go after this? You know, where is that navigation? So I think, you know, this program really worked well. I can't think of any barriers. I think what we need to do is probably start to plan a little bit sooner on it. But here it says, you know, it says, what do you think success might look like for this case in the future? One of the things that we're seeing is that we are siloed a lot of times. We don't even know each other exists, but now we've gotten into each other's lanes and we're kind of well aware of everybody. We're building our Rolodex per se, but our next plan, especially with the opiate abatement funds that we were able to acquire, is we're trying to build out a closed loop referral system that's in development right now, where we can connect everybody. I know that there's vendors out there that will come in and do that stuff, but they have to build it from the ground up. We were able to leverage our health information exchange, and they were already building out this platform. So as Cynthia talked about, you know, how do you get into the jails or into the prisons? We know that that's a little bit, we're trying to get the individuals to look at these individuals. Sorry guys, I know I'm done. We're trying to get these individuals to not look at it from a criminal standpoint all the time, but from a holistic standpoint of these individuals, so that we can provide that help and provide a little bit of preventative maintenance, I think is what's going on. So general discussion, you know, what can be done in the future to maximize these resources and opportunities involves, and how can state entities promote more collaborations? I think this is where we get the politicians involved, because it lets them put their hands on it, and they have, especially with our program here that we did that outreach, is that they provided a lot of volunteers. They got involved, and it just, the buy-in was tremendous. Do any of you guys have any questions? I know I was trying to talk and I probably missed a bunch of things, but I'm available if you'd like to chat. And I put my email in the chat thing.
Thank you so much for that great presentation, Joe. Yeah, at this time, we'd like to open up the floor to our learning network and our hub experts. Any questions that you all have for Joe on his case presentation for today?
Hearing crickets. Thanks.
Hello, I have a question, Joe. How did you get, like, for example, a lot of times the judges, come into play, and some of the politicians, they're part of it. They're the ones that, if we can educate them on,
Yes.
what are some things that are important. How did you manage to get some of those on board with you?
One of the big ways we were able to get them on board is that currently, I mean, I'm sure everybody has the challenges with mental health patients in ERs holding, being held, different things like that. So we have a group here in El Paso. It's called the Interfacility Task Force, and that's made up by the district attorney's office. So we were able to make some of those connections with them. So once they found out who we were, we started getting a little bit more participation from them. Another thing is that our city council does a pre-briefing to save time during the council meetings. So on those Mondays before the briefings, we're able to talk to those city council people on a one-on-one basis where there isn't a time limit of talking. You don't have any other distractions. You just have that time to tell them, you have the floor. And I think that's been a big advantage that we have. So you get buy-in from them, and they're well able, they want to do the best by their constituents, and this type of collaboration does that for them.
Thank you.
Jeremiah, I see you have your hand raised. Feel free.
Hi, thanks. I have a suspicion that the answer that you just gave, Deputy Chief, may be what I'm going to ask, but just in case it's not, and in case there's other aspects of it, I was curious about how how you've engaged local law enforcement in this, or help folks understand the value of what you're doing, or just to talk about that a bit.
What's really funny, sir, is that there was where we got that final bite with law enforcement being involved, is we were having some homeless encampment issues, right? But there was one particular officer, a commander, who she has that vision that we can't always treat everything as criminal. We need to look a little bit further into these things. Like Cynthia said, some of them have mental health. Dr. Miramontes said, they only have 3 days worth of their medications. And she saw the writing on the wall. It started in her area on the west side of town, but it was really funny because we met at a meeting, and I'm like, hey, I'm trying to do that. And she's like, I'm trying to do that. And that just really blossomed from there. And then the innovations team got involved in it with the community development program with the city. And you know what? They used to have a meeting that was where they started inviting partners, and there would be 5-10 people there. They had to move this meeting to a larger area because of all the different support. So I think a lot of it is just calling them and saying, hey, I'm Joe, and I do this, and I want to know if I can help you. So it's about that networking and building those relationships. And that's how we got PD involved. We're still working on them. They still sometimes just want law enforcement, but they're getting better.
That makes sense. And the story of basically finding that champion, and especially a champion with some leadership authority, that's like a really common theme, right? It's finding the person who's fired up and wants to bring it back to the department. Thanks.
But sometimes you get a change of gatekeepers that don't have the same vision. So then we luckily are the police and fire department collaborate well, and we have a good relationship with leadership. So I'm sure we could get through those barriers if they do come about.
Yeah, that's great.
Those are some great points. That's true. When you get individuals coming in to replace others, there's a lack of training, a lack of experience, a lack of knowledge, and then even just a lack of carrying over the philosophies that were there before.
Absolutely.
Kimberly, I see you
had her hand up.
Yeah, go ahead.
So here in Corpus, we have, actually it's today, every Thursday, I go to the library. We meet with several different agencies We have a homeless resource officer. That's what they do. They go out, they talk to these people, they know what the resources, because we meet every week. There's some individuals that we, get to know. And so we, we divide those resources up. And so as a peer support specialist, I want to go and I go along with them on the outreach because I have connections with all the agencies in town pretty much. And so we do outreach into the encampments and stuff, but there's a homeless initiative program, homeless initiative project that they also work under. So we get those resources out to everybody. It really works well. I'm so glad. We also have a ROSC. We started a ROSC back up, which is recovery oriented systems of care. Most cities have them. Ours just kind of waned off, and now we're picking it back up. And now, and we have a huge meeting once a month to plan, what agency, we pick an agency and what their needs are. And so we all as a community donate stuff to that agency for that meeting. And then the next month it's another agency. So it works really, really well. It's like that.
Thank you all. It's been a pleasure for me to be here. I really love this. Thanks again.
Yes, thank you for being here, Joe. We do still have some more time for questions. If anybody else has any other thoughts, comments, anything they want to share, experiences that they have similar to this, feel free to unmute. Go ahead, Jerma.
Well, you mentioned that you're, developing this, closed loop referral system and looking to continue to develop. And I was actually kind of wondering, how, or if there are any kind of insights you've had about how you've been able to learn about ways you've wanted to improve what you're doing, or gaps you've come into, or just the areas of need, or how you've gotten some of that feedback coming back your way. And if it's just random anecdotes are fine, but just kind of curious about that learning process.
We've been our health information exchange has been a champion with that, trying to develop that closed loop system, because they're not only engaged with the hospitals or the first responders, but they're engaged with United Way, different homeless coalition and stuff. And some of the things that some of the challenges that we identified is that not every agency has the same outreach capabilities. So sometimes they're stuck to those four walls. So we see them periodically at meetings and stuff, but with this closed loop system is that it's going to allow these individuals a little bit more flexibility, so that if we send a referral over to the food bank, they're not having to go out and meet. As we meet these individuals out there, that's where the MIH team comes in, because we're mobile. But as we see that, it's easier, and they're not trying to do, a simple, oh, we're having a pop-up here, or we're having a pop-up there. The referral system is live. So I think everybody sees the value in that. And then with the particular program that they're developing, it doesn't require anybody to change their computer systems or anything. The health information exchange will allow them access through, if I'm not mistaken, a web-based type of service. But we're seeing that throughout the community, even the physician groups and stuff like that. So it kind of built on our fall prevention program that we did, where we were doing we were able to pull data and stuff about falls and then follow up. So we're kind of just building off of that stuff, but we know that our partners out there sometimes don't have the same flexibility. So we're trying to make it accessible for everybody. I hope I answered your question, sir.
Yeah, no, that's great. And it also just sounds like y'all are super switched on. So that's awesome.
Great conversation. April, I saw that you did have your hand raised. Did you want to unmute and ask a question?
No, I'm okay. I was gonna ask something, but I feel like it was spoken about. I just did want to say, I feel so here at our agency we do have a certain department that we work with, also the fire department, and how do I say it? So I didn't want to speak about it because I felt like you were saying something like very similar, but I do know for us here at Sakata, they do work. We have an employee that works hand on hand with the fire department, and I think that it's such an amazing thing because he's as he's good getting these referrals and helping individuals, it's a very good tool for individuals who do struggle with, substance use or an overdose, and, being able to be connected and on site, helping with medication, helping, when it comes to Suboxones or any of, opioid use disorder. I feel, it's very helpful for our community here in San Antonio because, not like you were saying, that one person that's helping your organization, that's seeing that different vision, I think that's such an awesome thing to have for y'all's department, and I hope and pray that it continues to grow, because that is a very good tool to have in society, because they're that voice, for the people struggling versus, oh, they're just a criminal, they're just out on the streets, having a meltdown. No, there's something deeper. Let's get them that help. Let's, be that voice to help them, so we could not allow this to be happening right now. So whatever you're doing, sir, and you're in El Paso, correct? Keep doing what you're doing, sir, because, coming from, I am a person in long-term recovery, there's that stigma, and it's horrible, but being able to get more information to help your society is awesome. So, keep doing what you're doing, sir. You're doing a great job. Just don't give up. Our community, your community, individuals who struggle with substance use disorder, it is real, and it is very stigmatized, but there is hope for those people, and what you're doing, you're giving that hope to those who don't have that voice. So I just want to say great presentation, sir.
Thank you so much.
And thank you all so much for everything you shared. I see there's some great collaboration going on in the chat, Samantha and Lindsay. I don't want to call you all out. But as always, if you have any resources that you'd like to share with the Learning Network, feel free to drop those in the chat. We are always looking for more opportunities to just increase our resources. With that, I would like to go ahead and move on to the case summary for today. Jeremiah, could you please give us a summary of recommendations for today?
Sure. Thanks, Julio. Wow, today's been really a really good session. I see lots of clapping hands and hearts are coming across the screen here, and it was exciting. I think we started off, Cynthia, with your presentation on the really big needs that are come around reentry, and it's such a large wraparound set of needs that different places do it to different extents, different quality. But recognizing the challenges are huge is so useful. And then we were able to pivot over to what Deputy Chief Ortiz's program is doing in El Paso, where it has that kind of large scale ambition. And it started, as I understand it, in a fairly narrow request to be working with unhoused veterans, and then rapidly seeing that all these problems are so interconnected, and then the needs and the services are also interconnected, to ramp up, to de-silo as much as possible. And as you've gotten bigger and bigger in that process, finding that you needed to get more ambitious, and now working with different folks who have some ambitions, finding folks like the champion in the police department, getting connected with the task force run by the district attorneys, which has kind of plugged you more into the broader criminal justice system. helping folks understand the values and needs of what's happening. And then you have all of these service providers who are keen to help. They want to do their work, and you've got that health information exchange that's helping tie in information, so that seeing how you can want to build up the closed loop referral network. Having that kind of energy, the fact you're able to get some abatement funds. We are many years into this problem, so there's a lot of learning that's gone on over time, and so if you're able to bring everybody together as much as possible and keep adding people to this circle, there's hope. So I mean, I guess there's a bit of a where there's a whole lot of wills, and there's some money, and there's some real leadership, and there's encouragement, and people get on the same page. There's a way. This is great, y'all.
Thank you so much, Jeremiah. And thank you all for joining today's ECHO session. As a reminder, to earn your continuing education credits, please complete a post-session survey using the link that is in the chat. If you would like to present a case, please email the BeWell Texas team at bewelltexas@utesca.edu. We look forward to seeing you in our next session on Thursday, April the 9th. Have a great rest of your day, everybody.